Bethany, did you want to start us off today?
Yes. So thank you, Sarah. I have a big announcement, and some of you might have heard that effective October 1st, I'm stepping down as Director of Accords Education and turning over the reins to Sarah, who will be our new Director of Accords Education. So I've been really excited to lead this program in Accords for the last 5 years through a wide range of seminar series and workshops and conferences. I think many of you have attended CopperCon, and all of those things will continue under Sarah's leadership and with Jordan continuing to serve as program manager. So I'm very excited. Sarah's really put together all of the seminars already this year, and I've been able to take a step back. So I am very glad to be joining you all as simply an attendee of Accords Education moving forward. So thank you, Sarah and Jordan, and thank you all for being here. So I will officially turn it over to you, Sarah.
Thank you, Bethany. Well, I am Sarah Brewer. Thank you, Bethany, for the nice introduction. I want to welcome you all to today's Accords Education Program Seminar. I'm going to start with a little intro to Accords. So what are we? So it's supported by the University of Colorado School of Medicine and Children's Hospital Colorado, and Accords is a unique sort of one-stop shop environment for faculty to conduct pragmatic research, receive various types of services and supports for grants and projects, along with incredible mentorship, training, and education in health services research. So Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes. We provide a number of services, including a multidisciplinary collaborative research environment, strong methodological cores and programs, consultations and team building for grant proposals, again, that mentorship, training, and support for junior faculty and fellows, and extensive educational offerings, of which this is one. So today, before I introduce our speaker or hand over the mic to her, I just have a couple of housekeeping items for all of you about our seminars. So the first is that we use the chat to curate people's questions, comments throughout the talk. So please use that chat box to make comments, share questions throughout the talk, and we will have some moderated Q&A at the end of the conversation. And then second, at the end of the talk, we hope that you'll complete our very short evaluation so that we can continue to provide the best seminars and education offerings for all of you, both locally and nationally. We have some additional Accords upcoming events. So in a couple of weeks, on October 3rd and 4th, we have our Introduction to Qualitative Research workshop that we put on together with the Qualitative and Mixed Methods core here at Accords. There are still opportunities to sign up for our morning didactics as part of that workshop. You can find information on the website. And then we have our Community Engagement Forum, which is a quarterly offering, and our next one is October 19th. October 24th, we have the next seminar in this series around methods and challenges in health equity research, and we'll specifically be focusing on community engagement as a lens for doing this type of research with Monica Perez-Jole. And then in June, mark your calendars, save the date for June 5th to 7th for CopperCon 2023. All right. So I am going to go ahead and introduce our speaker. We have with us today Romana Hasnain-Wynia. She'll be talking about health equity research, what it is and why it is so hard to do well. Romana is Chief Research Officer at Denver Health, where she provides strategic direction and oversees research and sponsored programs through the Office of Research, and serves as a member of Denver Health's executive management team. Prior to joining Denver Health, Dr. Hasnain-Wynia served as the director of the Addressing Disparities program at the Patient-Centered Outcomes Research Institute, where she provided strategic oversight and leadership for the program's national funding priorities. She was the director of the Center for Healthcare Equity and associate professor at Northwestern University Feinberg School of Medicine, and she spent a decade at the American Hospital Association's Health Research and Educational Trust as vice president of research. Her research focuses on advancing equity in healthcare, with an emphasis on developing and integrating equity measurement in delivery and payment models. Today, the session will focus on an overview of health equity research and the major challenges in conducting and translating health equity research. Please join me in welcoming Dr. Romana Hasnain-Wynia today. Romana, the floor is yours.
Great, thank you. So nice to be here. I was talking to Sarah and Jordan earlier. I feel like I'm talking to people underwater. I'm really congested. I actually have COVID. And I have antihistamines and decongestants, but it feels like I'm underwater. So bear with me as I try to make my way through this presentation. I hope it's coherent, and I'm looking forward to your questions and comments. So thanks so much, Sarah, for the introduction. And as Sarah said, we're going to be really focusing on a high-level overview of health equity research and what it is, and why it is so hard to do well. Jordan has very graciously offered to advance the slides for me, so I really appreciate that. So the objectives for today are really, let's talk about what health equity is, how best to assess the evidence gaps in health equity research, which tends to be a bit of a challenge. And I bring this up mostly from my years at PCORI. The challenges of conducting health equity research, and then how do we really advance health equity in terms of making a sustainable and real difference? Because the conversations around health equity are not new. They have been part of the national dialogue for a very, very long time. But I do think we're at this, what I call window of opportunity. This is a phrase that Kingdon kind of coined, but it's this window of opportunity where there's different streams that come together that maybe open that window just enough to really make changes in policy and practice. And I think we may be at that time now. And if we really don't take advantage of the moment, I think it will be really discouraging for many of us. Next slide. So I'm not going to read these to you, but I just wanted to anchor us in what is health equity. So these are two definitions, one from the CDC and one from the Robert Wood Johnson Foundation. The emphasis for both of these is this focus on really attaining the full health potential of individuals and communities. There are many different definitions that we can pull around health equity, but I think that's kind of the guiding theme, that we're really looking at advancing opportunities for individuals and for communities to attain their full health potential. Next slide. So there's been a bit of a shift in the language of health equity research. So I've been doing this work for a very long time, and many of you probably remember when the Institute of Medicine released the Confronting Racial and Ethnic Disparities report in 2002. And there was this very strong focus on health disparities. That report in 2002 did a phenomenal job of really kind of saying, look, we know that disparities are real. They've been documented. They had been documented for well over 20 years. Dr. Jack Geiger actually took the lead in really compiling and kind of collating all of the studies that then made their way into the unequal treatment report from the IOM to document that we know that disparities are real. But the conversation started to shift from thinking about health disparities as a focus on identifying a problem to a focus on health equity, which is really, really thinking about how we can reach the highest levels of health possible and focusing on solutions, not just documentation. So again, we know that there's overwhelming evidence that health disparities are real, but the shift in language is really important in terms of even thinking about the research agenda for health equity as we think more about population level solutions. And this is a shift. Again, if you go back to 2002 and look at that unequal treatment report from the IOM, there was a lot of discussion about the importance of cultural competence. And it really took this notion of disparities down to that individual level. At the time, now 2 decades ago, when that report came out, there were a number of newspapers that highlighted it, the Wall Street Journal, the New York Times, and the headlines were "Doctors are racist." And so it really kind of took this conversation and shifted it to, what do we need to do to create cultural competence? The shift has moved from this individual level to much more institutional, and thinking about the structural and systemic impact of racism in our country and how it affects multiple populations based on race, ethnicity, based on disability, sexual orientation, gender identity, and so forth. So the shift in health equity research really involves developing and implementing interventions at multiple levels, at the neighborhood, local, community, state, and national levels, and really thinking about how research can inform policy and practice. Next slide. So I always like to use this, and I believe that many of you have probably seen it, but this is a report that the Commonwealth Fund, which is a foundation in New York City, produces pretty regularly, called Mirror Mirror. And the Commonwealth Fund, it's a great resource, but it kind of anchors how we're doing as a country. And I'm always indebted to the Commonwealth Fund, because I will say that the Commonwealth Fund was one of the first foundations to give me my first grant, and then multiple grants afterwards, that really started my career in health, doing health equity research. But really what the Commonwealth Fund report in 2021 showed is that when we compare ourselves to top performing countries such as Norway, Australia, et cetera, we rank last on access to care, administrative efficiency, equity, and healthcare outcomes. Next slide. So this graph just kind of shows graphically where we sit. If you look at these other countries, we are at rock bottom. One thing that I want to emphasize here is, I said that the conversation about health equity started with a conversation about disparities. We've really started talking about advancing health equity, but in the midst of this, we've also started talking about the impact of what we're calling social determinants of health, with this recognition that equity can't be achieved if we just look within the walls of the healthcare system, and that we really need to focus as well on the social health. Part of the reason that I think that we sit at the rock bottom compared to other developing countries on the measures that I just articulated is because, compared to these other countries, the United States has a much weaker social safety net, meaning weaker social safety net around housing, around food insecurity, and so forth. And so this is a bit of a larger conversation about what we need to be doing as a country in terms of strengthening the social safety net. Right now, the conversation about social determinants really sits centrally with what can the healthcare system do. I'm just going to argue that I don't know that the healthcare system is the best system to address the social needs, but that's where the money is. And so right now, the focus is on really thinking about what kinds of partnerships with community-based organizations and others can have an impact on addressing some of the social needs that we see within our communities and our patient populations in healthcare systems. Next slide. So I know that all of you know that health disparities and advancing equity are driven by social and economic inequities. We talk about social determinants. I don't love the term social determinant, mostly because it implies that things are determined, and I don't know that they are. So next slide. So I was recently at a conference and listened to a presentation by Dr. Bashara Shoker, who is executive VP at Kaiser in Oakland. He also served as the White House coordinator for vaccines for 1 year under Biden. And during his presentation, he was talking about what Kaiser was doing in terms of addressing social determinants. But what I love what he said here. He said, instead of thinking about this as social determinants, we think about healthcare in terms of healthcare systems meeting the physical needs, the mental health needs, but we also need to talk about the social health. And so I really like the idea. I like the way that he framed this. So I wanted to share it with you because I do think that it's important for us to change the way we talk about social health and not necessarily think about it in terms of social determinants, because these are not determined. These are actually changeable. Next slide. So where should our focus be? And so again, I just want to anchor us back to where we were in 2002, probably into about 2010. There was a lot of conversation about the importance of cultural competency training. And there were many, many programs that have been developed around teaching cultural competence, whether that was at the individual level for clinicians or for organizations. We've kind of shifted that language to talk about implicit bias training. I'm not saying that implicit bias training isn't important. I think it's necessary, but it is not sufficient. Clyde Yancey, who is a cardiologist based at Northwestern University, wrote a phenomenal piece in JAMA in 2020, arguing that we've all kind of gotten on the equity bandwagon and we're implementing a lot of strategies that don't have a strong evidence base associated with them. So we don't really know if they're going to have an impact in making sustainable change. And so part of what he argues in his JAMA piece is that we really do need to develop the evidence base because we're doing a number of activities. I know my own organization is, I've talked to multiple colleagues across the country around what are we doing as organizations to advance equity. And I will say that, implicit bias training is important, but it isn't sufficient because we need to be addressing the root causes of structural racism and use system level approaches. And part of that is really integrating equity measurement into alternative payment models, meaning we should pay for it, and integrating equity into delivery models. Now, this is something that CMS is currently very engaged in. I serve on a committee for CMS where we are talking about how to integrate equity measurement into both alternative payment models and into delivery models. And I'm hoping, this is the cynic in me, I'm hoping that if we integrate into payment and into delivery models, we might actually see some level of sustainable change. Next slide. So let's talk about systemic and structural racism in healthcare. And I'm going to take a sip of my tea, if you could just give me a second. Next slide. So again, I just want to anchor us back into a context of kind of where have we been. So systemic and structural racism, we all know that it's real. And what we've known from many studies conducted is that where a person goes really matters in terms of their healthcare outcomes. So between 1994 and 95. So this is not that long ago, at least in my world. Most US hospitals did not admit any Black Medicare beneficiaries. Black AMI patients were admitted to only 1,000 of the 4,690 acute care hospitals nationwide, and 80% of all primary care visits by Black patients were made to 22% of physicians. So you can see that structurally, we had created a system that was separate. Next slide. So why does this matter? So I wanted to bring up, intentions are good. I believe that people work with a focus on good intentions. So Massachusetts, in 2006, decided through, so Judy M. Bigby was the Secretary of Health and Human Services at the time, decided that as a state, they were going to pay for performance for reduction in health disparities. So what they set up as this program was a model where hospitals would have to show through a checklist that they had instituted a bunch of measures that could align with being culturally competent. Well, I'll tell you what happened. Every single hospital could check those boxes, and they were able to show kind of organizational cultural competence, and that's the term that was used. But they also had to show a reduction in disparities for specific measures. But they couldn't show the reduction in disparities for specific measures because the concentration of individuals to look at a disparity, the concentration of individuals from different racial or ethnic backgrounds was not sufficient to be able to measure a disparity. So what ended up happening is that all the hospitals got a payment for for being culturally competent, but there wasn't the capacity just because of the patient population in Massachusetts and how they were distributed across hospitals to actually show a reduction in disparities for specific measures. So the reason I bring this up is because as we think about policies that are well-intended, we have to understand the context of whether those policies will work or will not work, given what our goals may be. Next slide. So, Jordan, you're gonna have to keep hitting the, hit it, yeah. So, and just keep hitting until probably, yeah. Thank you. I forgot that this was one of those fade-ins. So the evidence around kind of where you go matters is pretty pervasive. So this is true whether it's in nursing homes, skilled nursing facilities, primary care, whether it's in acute care hospitals, but the literature on kind of where you go to get your care really has an impact, speaks to the issue of structural racism and the importance of policies and practices that really think about our payment models and also our staffing models, because these are all interconnected. Next slide, please. So where you go matters. Care for poor patients is concentrated among a few providers, and the challenge that this brings up is that with any given hospital or health system or even a practice, it's rare to be able to document disparities at a statistically significant level. Next slide. So beyond our narrowly kind of defined notions of looking at quality measures, and we've been really good at looking at process measures, but as we've started to move towards advancing equity and we start looking at outcome measures, we recognize that what happens within the walls of the healthcare system is simply not enough. And that's why we start to focus on social health. And that really kind of gets to the importance of community partnerships, working with organizations outside of the healthcare system. I know you're going to hear a talk about this in the next couple of months in terms of engagement and drilling down a bit more. But what I want to bring up here is that as we think about health systems partnering in the community, one of the things that we really haven't been able to grapple with is where does the payment go? Stuart Butler, who's an economist at Brookings, has written about models of braiding and blending. But if, for example, we see improvements in outcomes, if the health system works towards being able to discharge patients to supportive housing, does the payment come to the hospital or does it go to the partnering housing agency? This is an area that we're still really grappling with, and the research in this area is pretty scant. The accountable care communities had some good models in place, but I still think that we need better evidence how we can really advance what we're doing as healthcare providers and healthcare systems in terms of partnering with our community organizations, community partnerships, et cetera, to really be able to address the social health of the individuals that we serve and the communities that we're here to serve. Next slide. So this is very simply to say that advancing equity requires input at multiple levels, and that makes it a bit complicated in terms of studying it, because ultimately it calls for multi-level, multi-component interventions. You can have the best clinicians doing the best job that they can to provide the best possible quality of care, running hard and fast to do this. And we saw this during the COVID pandemic. But if we don't have the systems that support them from the top, it makes it very, very challenging. And it's very challenging for advancing equity. Next slide. So I've talked a little bit about a little bit of history, a little bit about the complexity of advancing equity. But as researchers, how do we assess evidence gaps in equity research? How do we know, kind of where is there a gap, and how can we make an important contribution, especially when we think about areas like asthma or diabetes, obesity, et cetera, where we know that so much work has been done, but there is still some big questions about why we're not seeing the closing of the gap, if you will. Next slide. So why do evidence gaps exist, particularly for underserved populations? Ultimately, what I want to say is that one thing that we know is that we have done some really phenomenal efficacy trials. So we need to move towards effectiveness trials to see what works for whom, under which circumstances. Right now, in terms of underserved populations, we don't, there's insufficient information. How many studies have been conducted? How large are the studies? Who did the studies include? These are the questions that we need to be asking. There also may be bias in the information. Are the studies of high quality? Do they measure effectiveness for specific groups? What works? Are the findings inconsistent? So how do we go about as researchers trying to kind of cull where these gaps are so we can target our studies and our interventions in the space where we can make the biggest contributions? Next slide. So how do we identify evidence gaps? So obviously, and we know this, the funding environment is tough. We need to rigorously justify the need for the study and what the study contributes. We need to be able to identify what is not known. And did a policy or a practice get ahead of the evidence? And this has happened. So back in about 2010 or so, CMS passed, basically said that they would pay for obesity counseling in primary care practices and stipulated that the counseling had to be done by a primary care physician. Well, is that the best model? We didn't know, but the policy went ahead of actual evidence. So part of the work while I was at PCORI was to fund large trials to really see, are there different models? So, one question to ask is, if there's a policy, did it get ahead of the evidence? Identifying gaps in the evidence in terms of representation. So whether you go to the Cochrane literature, the library, or to ARC, and I'll talk about ARC a little bit more, but there are ways to really be able to find where the gaps are for specific populations. It's important to find and evaluate the content of relevant systematic reviews and the quality of the systematic reviews. Some are really good, some aren't. And then really think about the trade-offs between breadth, feasibility, and generalizability. A systematic review may not be appropriate if there's only been a few high-quality studies in a given area. Next slide. So part of thinking about how to identify evidence gaps is thinking about the hierarchy of the evidence base. So understanding where the evidence gap exists is important in conducting research, which will have an impact. If you have a question and you look at systematic reviews on a topic and find that there are 3 really high quality reviews, you will really have to focus on where the gaps are in terms of how they were identified in the systematic reviews. If you find that there aren't systematic reviews and the literature really kind of ends at the bottom of this pyramid at case-controlled studies or on expert opinion or on cohort studies, it may actually identify an area where for specific populations, a more rigorous study, such as a randomized controlled trial, needs to be done. So there are multiple places that one can go to look at where the evidence is well synthesized to help find those gaps. Next slide. So there's different types of evidence syntheses. There's the classic systematic review or meta-analysis. These are very resource intensive, they're rigorous, and they take a lot of time, but ARC produces these. There are also rapid reviews or landscape reviews or technical briefs, and these cater to more urgent deadlines. They're not as rigorous, but they're actually quite informative if they're done well in being able to identify where a gap in evidence exists. And then you have scoping reviews and evidence mappings, which are really developed to set out or map the literature in a given area. Next slide. So as I said, ARC is a great resource. I have to tell you that, before I went to PCORI, I was a researcher, I was doing research. I did not know that ARC produced really quite rigorous evidence reports, whether they were full-on systematic reviews or whether they were technical briefs. But ARC works with evidence-based practice centers around the country, University of Minnesota, Hopkins, Oregon Health Sciences University, Vanderbilt, et cetera, to develop these very rigorous evidence syntheses. And it is a great resource. So if you're thinking about a particular study in a specific area, I would strongly recommend that you use the evidence synthesis reports that ARC produces. So it's very interesting. So ARC produced a systematic review in 2011. I served on the technical expert panel to look at whether quality improvement activities could play a role in reducing disparities. Unfortunately, that report had very stringent inclusion criteria. So we only ended up with 19 papers over 20 years that met the inclusion criteria, because we said that a study had to have two populations to be able to measure a disparity. So ARC is redoing that synthesis right now in the form of a technical brief and an evidence map. They're looking at the evidence around interventions, health system interventions, and then looking at the dyad between clinician and patients to look at interventions that work to advance equity. And those reports should be coming out within the next year. Again, they're just a great resource if you're a researcher. To me, it's just really important to call the evidence in terms of where the gaps exist. Next slide. So these are just the types of evidence reports that ARC has developed. You can look at the titles here, everything from mobile applications for self-management of diabetes, to medication-assisted treatment models of care for opioid use disorders. What you might find here is that these reports sometimes really do a great job of highlighting where the studies have focused, and more often than not, they have not focused on underserved populations. So right there is an evidence gap in terms of what works for whom. So it's a great setup for effectiveness trials. Next slide. So advancing equity. So it's challenging, we know that. Next slide. So when we're doing equity-focused studies, there are certain things that I think are incredibly important. First of all, a study has to be motivated with an equity focus. It's not something that could come in kind of as an add-on. So it's really important to clearly describe patient populations and subpopulations, to clearly describe the intervention group and any enhancements, to pay attention to heterogeneity of treatment effects. And if it is an equity-focused study that is not powered to the target population, it is not an equity study. Equity should not be an add-on. And I say this mostly, again, based on my experience at PCORI, because we would get these studies that would come in with these great rationalizations of, we want to address equity, we want to make sure that we reduce disparities, but then we looked at the methods, the study wasn't powered to the target group. So again, I just want to emphasize that a study has to be motivated from the get-go, and then the methods have to align to be able to really be able to say, we've focused this as an equity-focused study for X population, and the methods align with the motivation, and our recruitment also aligns, the importance of community engagement, and so forth. Next slide. So I do not expect you to read this. I really tried to make this more legible, but then I got tired, frankly. But I put the reference here. So this is actually a really great paper that came out in the Journal of General Internal Medicine last year. And it's basically a qualitative assessment of a health equity research impact. And it provides 32 checklist items. They're qualitative, there's no score associated, but it really forces kind of asking the right questions. Not every study has to align with all 32 of these items, but I reference it because I think it provides a really nice framework to thinking about the health equity impact of any given research study. Next slide. Again, the complexity of advancing equity and equity research is that we know that the research that really makes the most contributions is multi-level, multi-component, which makes it more complicated. But in many ways, this is messy work because we're talking about real world settings with real populations. So again, I want to focus on kind of the studies that really, I think, have the most possibility of advancing equity tend to be multi-level, multi-component interventions. Next slide. Again, this I'm not going to read to you. This is an implementation model in terms of highlighting the effectiveness of interventions, the evidence and the context of the assessment, the audience identification, because at the end of the day, when we're thinking about advancing equity, what I'm hoping, and I know this is true, that there are many areas where efficacy trials have shown that something works. What we are really challenged with is how do we make sure that what we have shown works for more underserved populations. Next slide. So I'm going to end with the data challenges in terms of equity research, current and future data challenges. Next slide. So as an equity researcher, one of the data sets that I think are, have the capacity to be rich and usable are Medicaid administrative data. But there are a lot of challenges with data in Medicaid because of the lack of good data on race, ethnicity, and other demographic variables. All 50 states collect this information differently. There's variation in how the categories are used, but it's still better than nothing. The problem with using Medicaid data, and I've had this conversation with many of my colleagues during policy discussions as we focus on Medicaid, is that Medicaid doesn't include our refugee population or uninsured population. So we're leaving out a very, very vulnerable group. Next slide. The other thing that's coming down the horizon, it's here, is this issue of data poverty. And the digital divide, the use of AI and machine learning. So we really need to increase awareness with data and digital health communities and beyond. There's an opportunity for the health data research and digital health communities to really be advocates for what I consider to be data deprived individuals, groups, and populations. This is, I'm not an expert in this area, but I'm bringing this up because the issue of data poverty is very real. So I was just at a conference where Dr. Lisa Lehman presented. Lisa used to be the head of bioethics at the VA. She's a physician and a researcher. She's now the head of bioethics for Google. And the example that Lisa gave during this talk was really quite interesting. She was saying that, if you look at melanomas, right now, AI does a much better job of being able to identify melanomas, but it doesn't do a good job for darker skin individuals. And the reason for that is because there is a scarcity of data, sorry. There's just a lack of data. So I think that as we think about the digital divide, we think about AI, we think about machine learning, we really have to be aware of who we're leaving out. So this is a huge opportunity in terms of advancing equity and equity research. Next slide. I just want to highlight Denver Health because I've talked about data scarcity and the lack of good data. Next slide. So Denver Health actually implemented the REAL initiative in May of 2021. We basically, REAL stands for race, ethnicity, and language data, but we're also asking information about country of birth, and we're going to be adding other demographic variables. But as an organization, as a health system, we felt that it was really important for us to have better data about our patients. So we developed an awareness campaign, developed tools and training for our frontline staff, changed our fields in Epic, and we are currently doing ongoing evaluation. I want to credit Laura Potawells, who's my colleague at Denver Health, for this slide. Next slide. And I have to say that, a year into this, we've seen a remarkable change in the quality of our data. Our missing variables have gone down from 7 to 14% to about 0.5%. We've been able to capture data on 284 different ethnic backgrounds, on 117 different primary languages, and 183 different countries of birth. the reason I think this is really important is that this conversation about health systems collecting better demographic data ties into what health plans can do, because right now health plans are grappling with this. The NCQA is working with health plans, the Blues, Medicaid plans around how can they get better data. It's easier for health systems to collect these data than for plans, because I don't know how many of you get to have direct encounter with your health plan where you have a little bit more consistent encounters with your healthcare providers. So the importance of really thinking about the type of data that we have is so important, because if we don't have the right data, we might actually perpetuate structural racism. Next slide. So I'm going to end by quoting myself. I was asked to do a book review. I really think ultimately that advancing health equity is at the evolution of research. It's really, we are on the implementation side of this. We need to be able to implement and disseminate what we know works. So evidence may be the cornerstone of a high-performing health system, but the irony is this: for those who wish to see evidence-based medicine implemented, more and better medical evidence might not be the answer. Rather, we need better evidence about how to implement what we already know. And I think this is incredibly true for research that is focused on advancing equity. Thank you so much. Thank you for bearing with me. I'm sorry that my voice is so hoarse, and I'm happy to take questions.
Yeah, thank you so much, Romana. I'm watching the chat here. We have a few questions already coming in. Jen pointed out an important trend in research, that people who are doing other kinds of research have started pivoting to health equity, but potentially without always developing the necessary scientific expertise, methodological expertise, to really do high quality health equity research. How do we combat that, or better support those people who are trying to move into health equity research space?
You know, it's fascinating. There was a really great stat article that came out kind of about this issue of all of a sudden people are kind of just, you know, going in droves to do health equity research without having any background in this. I don't know that we can stop them. I do think that it's incumbent on leaders and funders and reviewers to be very cognizant. I think that there is much more focus on being more inclusive, not just in research, but also in publications. So I don't know what the solution is, because I think, you know, I hate saying it this way, especially as somebody that has been working in this field for the last 30 years. But sometimes it feels like it's the flavor of the day, and it's not. It's a really important issue. And I think, you know, the best way to maybe address this is, you know, if you want real change to happen, you don't want it to be kind of just sequestered in a corner with a few people doing it. You really do want there to be broad uptake, and you want people to be committed. So I do think that partnerships are really important in this space.
Yeah. Sort of follow on with that, Stan asked the question about journals and publications. So do you see high profile journals changing their direction to better encompass health equity studies, such as dissemination implementation research, as compared to the sort of typical gold standard of randomized control trials?
Yes, and there was a really good paper that came out maybe last year. The senior author was Namratha Kandula, looked at kind of NIH funding and where you know, kind of the NIH review process, NIH funding, who gets NIH funding. And part of what they highlighted in this paper was that sometimes the community engagement, you know, this issue of kind of the methodology is not valued. And I think that NIH is beginning to take a very different approach to this. You know, change is hard. I will say that our, you know, in some ways, you know, the study sections and peer review panels are very entrenched in our way of thinking. You know, I had a really interesting conversation. I serve on this committee for ARC called the SNAC. It's a subcommittee of a larger committee that's focused on how ARC should use the PCORI Trust Fund dollars. And part of the conversation was, how do we change the measures of success? So there is more focus on the importance of engagement. There is more focus on the learning health system model and implementation and dissemination. And I'll say that, we're beginning to see that shift. I don't think that there's been a tidal wave of change, but we're beginning to see that shift.
I'm going to go ahead and just read this question from Corey. The title Safety Net Hospital just screams health inequity, considering we still need a safety hospital for patients where other organizations might not offer them the safe care they required. We're curious about your thoughts on that and what that might mean for health equity moving forward.
I'm not sure I understand the question.
Yeah, so it was mostly a comment, but they're curious your thoughts about sort of the need for safety net hospitals and how that fits into health equity more broadly.
Yeah, I think safety net, it's really interesting. So, safety net hospitals have been around for a long time. Denver Health identifies as a safety net. Cook County, Stroger, Parkland, the list is long. What is it called? America's Essential Hospitals, which used to be the National Association of Public Hospitals, changed its name under Bruce Siegel when he became the CEO to become America's Essential Hospitals. Part of that shift was because essential hospitals were not just public hospitals, that they should be broader, right? So there was kind of this focus on there should be a safety net for everybody at every hospital. I don't think that that's necessarily changed it, kind of changed how we practice healthcare nationally. But right now, I think that the role of safety net hospitals, and they are called safety net hospitals, is really, really important in terms of being able to advance equity. Part of what I've said as an equity researcher is that if you want to really advance equity, you need to go where the patient populations are.
We have a couple of questions about the REAL program at Denver Health that you shared a little bit about. Can you speak a little bit to how you were able to get so little missing and other data and how that's sort of aligned with data collected in other ways like research?
Yeah, so this is all within our EPIC system. I'm going to say that, I've been talking about data collection for 20 years. I think, the first grant I said I got from the Commonwealth Fund back in, 2003, was around understanding what hospitals were doing around race ethnicity data collection. And then there was an IOM committee report in 2011 that laid out standards for standardizing race ethnicity language data collection. And I'll be totally honest, we did all these studies, we published all these papers, and I finally just said, look, the evidence is there. There's not a will for organizations to make a change. In 2020, Robin Wittenstein, who was the CEO of Denver Health until about 2 or 3 weeks ago, came to me, it was the fall of 2020, and said, I didn't realize that you'd done all this work on collecting data. I would like you to make sure that our data collection practices are better. So this was not, the Romana show. This was probably 30 people across the enterprise that came together that really focused on kind of how do we do this in a systematic way. We developed scripting. Maria Casaverdis was phenomenal, who really kind of went and trained individuals on the ground. We worked with our EPIC team to make the changes in EPIC. There was just a huge organizational commitment and push to do this. Everybody from our frontline staff to leadership. What I will say is that leadership has to make this a priority, and that's how we were really able to do it. We go back, we look at the data consistently. We look at where we might need to provide some kind of, if you will, boosters in training to see if things are beginning to slip a little bit. But really, this was a very concerted effort with a lot of champions across Denver Health to make this happen. And it's really remarkable, the return on investment in terms of the quality of our data. So when we look at our quality data now stratified by these demographic variables, we have much more confidence.
That's great. We have a question about building health equity in rural spaces. So what recommendations do you have? I think a lot of our work has been in sort of race and ethnicity equity and in urban spaces. So what are your thoughts on building equity in rural spaces?
Yeah, I mean, I think this is a hugely important question. And, part of it around equity is really around access. And so right now, I mean, I think, where we're really looking is, the kind of the promise, but also anytime there's a promise, you have to think about the potential pitfall of a given technology. So telehealth is an area that I think there's a huge focus where we really need to be able to develop evidence to show that telehealth may expand access, but it should not be at the cost of quality. So that's where we're trying to find the balance. There have been some really great studies. Dr. Fortney, who's based at the University of Washington, did a phenomenal study looking at the quality of telehealth for serious mental illness in terms of expanding access. And, the study was very positive, but I think that is an area where we could really work to expand equity or advance equity in rural settings. I'm always cautious about a solution, but thinking about the unintended consequences. So.
Great, thank you. We have just a few minutes. I want to remind everyone, Jordan put this in the chat a couple minutes ago, but please do our evaluation. It helps us to keep our seminars responsive to your educational needs. And if you do it right now, you'll be done before we even wrap up. Bethany has a question. Some of my collaborators were recently told by an NIH program officer that their proposal needed to address social determinants of health. How is that different from health equity research in your mind?
Yeah, I've really grappled with this. So, I gave a presentation a few years ago at a Princeton conference around social determinants of health. And so I gave my talk, and afterwards, the president of the Robert Wood Johnson Foundation came down and spoke to me and said, you talked about social determinants, but you didn't talk about health equity. And if we only talk about health equity, if we only talk about social determinants, without an explicit focus on health equity, we may actually be making the vulnerable even more vulnerable. So when we think about housing and we think about food instability, we still have to think about coupling these with equity measures. That was actually pretty profound for me because I hadn't really thought about it. I had started conflating them, and I think they're actually very distinct. So health equity can, even if you're fully addressing social determinants, you can look at kind of the subcategories where we could be driving inequities further if we don't have a lens of equity coupled with social determinants. I don't think they're the same thing.
Okay. All right. Any last questions before we wrap up for the day? People a second. Okay. Romana, thank you so much for being with us despite your illness. And I hope you feel so much better.
Thank you.
All right. Please, again, complete the evaluation and look for some of our upcoming seminars in this series. Just a reminder, our next one is October 24th with Monica Perez-Jole. Thank you all so much. Have a great day.